I'm Tom Stinchcombe. I'm a medical oncologist who specializes in thoracic oncology. I work at Duke Cancer Institute in Durham, North Carolina. I think patients can present with a variety of symptoms for brain metastasis, and I think this is one of the biggest clinical challenges, that there's not the classic smoking gun symptom. Some patients will report with stroke-like symptoms. I have trouble speaking, I have trouble with word finding, I have trouble moving an arm or a leg, and in the most dramatic cases, seizures. And I think those are very dramatic, and we try to avoid those if at all possible. Now, some patients present with those symptoms and go to the emergency room, and that's how they are found to have cancer. I think the other symptoms that are more subtle, there can be some problems with doing the crossword puzzle, some just generalized confusion. And I think when patients are sort of in with an oncologist and being seen regularly, I think our threshold to do brain MRIs are pretty low, because in lung cancer, we know a significant number of patients are going to progress in the brain. And if there's subtle symptoms, or if you have to worry about it, it's probably worth doing the MRI, sort of my approach, because then it's very reassuring to the patient, family, and frankly, the provider that we don't have a new problem brewing. And so I think those are the issues. And I think once you have a brain metastasis, I think it sort of depends on the subtype of lung cancer you have, because many of the oncogenic drivers, such as ALK positive, non-small cell lung cancer, EGFR positive, have drugs that can effectively treat the brain metastasis with a pill, and that's ideal. I think the other cancers, the ability to treat the brain metastasis with a systemic therapy, or is what we call it, is still in development, but I think we will often use chemotherapy and immunotherapy if the brain metastasis is very small and the symptoms are minimal. I think often if they're symptomatic and there's a quality of life issue, I see these patients in conjunction with my radiation oncologist, and we kind of make a decision between the two of us as to which would be the first priority in terms of treatment. And most of the very symptomatic brain metastasis patients will get some form of brain-directed therapy first, and then I'll follow with systemic therapy or the other treatment options. I think the one thing that also sort of complicates this discussion is that if there's a very large brain metastasis that's exceptionally symptomatic, we do talk to our neurosurgeons, because sometimes if it is surgically resectable, that can alleviate the symptoms very rapidly and effectively. And so I don't think we want to necessarily exclude the possibility of neurosurgical resection if the patient is an appropriate candidate. This is obviously a complex decision depending on the location, the morbidity of the surgery. And so I think it's very complicated, but I think it's a very interesting time, because I think historically brain metastasis are thought to portend a poorer prognosis. But with our advances in therapies, the patients with brain metastasis, some are living many years now, and I think we've made dramatic improvements in what used to be a very sort of serious and a morbid diagnosis or complication from the cancer. We also do a lot of supportive care medications. Like most patients will be started on dexamethasone, because in addition to the tumor, many times there's swelling around the tumor, and you want to reduce the swelling, which can result in an improvement in the patient's symptoms in a matter of several days. I think the important thing with the steroids is we want to start at a good dose, but we want to taper you, because we don't want people on steroids long-term, because it can cause problems with mood, increased emotional liability, blood sugar problems, reflux. And so if you need them, yes, but we want to make sure that they don't sort of continue at a high dose in perpetuity. Generally, if patients have seizures, they get started on Keppra. At that point, they of course prevent another seizure. And I think that this can be challenging, because then unfortunately the patient can't drive for a period of time until and so that they have some loss of independence. I really want to make sure the patient actually had a seizure before I commit them to PEPRA and take away their driving privileges, because I think that there sometimes can be some vague histories or unclear things, and we don't want to reflexively attribute to the, things to a potential seizure and then have to commit to another medication and taking away a patient's driving privileges.